Greetings again, video fans. Today we're going to talk about transfusion reactions that occur for non-immune problems. And these are relatively common and are relatively straightforward pathologically, however, it can become quite a problem. In the first video we talked about immune-based transfusion reactions, and in this video we'll move on from there. The most important non-immune transfusion reaction that we deal with is what's called transfusion-associated circulatory overload, or TACO for short. This can be due to an absolute volume that's excessive, or can be due to the rate of transfusion, which is excessive. Commonly, this is seen in surgical cases where large volumes of fluid are used and blood products are used, or in situations where large amounts of blood are infused rapidly. The symptoms include tachypnea, tachycardia, orthopnea, hypoxemia, hypertension. If you watched our last video, you'll note these symptoms are similar to the symptoms associated with a lethal transfusion reaction called trolley. This differs because this is a fluid-based issue as opposed to an immune-based issue. Also differs because this is usually treatable with diuretics and less aggressive support. To differentiate TACO from trolley, remember, you can eat a taco, but you can't eat a trolley. Tacos don't normally require intubation. Trolley patients frequently require intubation and thus can't be eating. So your patient can eat a taco, but not a trolley. Differentiating them medically, CVP is elevated in taco, but not in trolley. Pulmonary wedge pressure, should you have a SWAN, would also be elevated in taco, but not in trolley. Laboratory studies include BMP, are abnormal in taco, but not in trolley. And so if you don't have a SWAN, you can use a jugular venous distension on physical exam. You can use a CVP line if you have one, or you can measure a BMP if you don't have either. Treatment for TACO is supportive therapy with oxygen, aggressive diuretics to mobilize fluid, and if this isn't adequate, sometimes phlebotomy is used to remove blood cells. To prevent this, restricting the amount of blood given in a given day and restricting the rate of blood transfusion is usually adequate. For example, a 10 cc per kilo transfusion load given over 4 hours will result in a 2.5 mLs per kilo per hour infusion rate, which is generally considered safe for children, and thus the risk of a TACO formation, a TACO event occurring in your patient is much reduced. Febrile transfusion reaction is actually the most common and used to be vastly more common than it is today, thanks to the presence of donor side leukofiltration. Febrile transfusion reactions are an immune reaction in some cases where the host defenses kill transfused passenger white blood cells from the donor, but these can also occur for non-immune causes and are frequently associated with older units transfused after the white blood cells in them have begun to die and release cytokines into the cytosol, the extracellular fluid of the transfused unit. And those transfused cytokines then react with the host to create fever, and they can create other symptoms as well. And the differential diagnosis is usually considered to be infection, acute hemolytic transfusion reaction, or trolley. The treatment for this is to stop the transfusion, to send cultures from the patient and the unit, and to consider further evaluation for infection, such as a chest x-ray or such, and then use Tylenol for antipyretic effect, and then antibiotics as judged warranted. Infection is a rare complication now of transfusion. There is much lower incidence of HIV, hepatitis B, and C and B than previous. Also, Omaha is blessed by having a large donor pool of volunteer blood donors, and the presence of a volunteer blood supply itself lowers the risk of infection. Viral infections we still deal with are CMV, hepatitis B, and HIV. Bacterial contamination of the unit, while uncommon, is our greater concern, though, frankly, than viruses. Differential diagnosis includes acute hemolytic transfusion reaction, febrile reaction, or intercurrent infection from some other source. All these considerations have to be weighed when you evaluate a patient at night. After all, the patients you're going to be given blood to are patients who've either had a great deal of surgery and thus have open wounds, or have large bore cannulas, or other risks for infection, or they're perhaps oncology patients who have mucositis, neutropenia, and thus have risks of infection besides the transfusion you've given them. The treatment of this, again, is to stop the transfusion. Once again, written in red, because this is one of the basic golden rules of transfusion reactions, as you heard me discuss in transfusion video 1. We culture the unit and we culture the patient. It's important to get peripheral vein cultures from the patient, not peripheral blood from the central line. Viral titers is indicated, and antibiotics is indicated. For the dosing of these antibiotics, look at the fever and neutropenia video from the UNMC Pediatrics night course. Mechanical hemolysis is not as common a problem as it used to be. Fortunately, because we have better IV pumps and because we have a better understanding of how the blood cells respond to the IV pumps. Red cells can flow through a large bore catheter easily. However, a lot of our children, particularly our babies, have small bore catheters, peripheral IVs, which are very small and are difficult to get blood through without breaking them. Additionally, rotary pumps, which add stress to the red cells or platelets, can either destroy the red cells or platelets or cause inappropriate activation of the platelets. High pressure IV pumps that use other means besides rotation to increase pressure on the fluid being pushed through the cannula are also an issue because they can spray that blood through that tiny catheter, resulting in hemolysis. We now are able to avoid that by having platelets hang by gravity and have red cells infuse through a lower pressure pump. One thing we do run into problems with periodically, particularly in children, is the need to run blood through incompatible IV fluids. And thus, we will flush an IV before and after the transfusion to avoid that incompatibility. And it's important to do that. So when the nurse wants to hang a little bit of normal saline before and after the transfusion, do it. Differential diagnosis of mechanical hemolysis is going to be important because this will save you a lot of workup and a lot of worry for the family. A negative antibody screen, schistocytes in the peripheral blood smear, and a stable hemoglobin, the hemoglobin that will not continue dropping. This separates it from a delayed transfusion reaction where hemoglobin can continue to drop. This also separates the concerns regarding other causes of peripheral destruction such as DIC. So if you have questions about these, drop me an email and we'll